Welcome to the Explainer. Let's bypass the basics entirely and jump straight into the clinical material with a rapid, high-impact overview of multiple sclerosis management. We're calibrating this strictly for an elite 280-plus board score. Today, we're dissecting the absolute pharmacologic boundaries that separate acute inflammatory exacerbations, chronic disease modification, and symptomatic management. By mastering these strict pathways, you're going to be fully prepared to execute the correct medical mandates in even the most complex clinical simulations.
Okay, let's dive right into the inflammatory breach. An acute MS exacerbation is driven by active, contrast-enhancing demyelinating plaques in the central nervous system. The clinical signature here, it's undeniable. You'll see focal neurologic deficits, things like optic neuritis, internuclear ophthalmoplegia, or transverse myelitis, developing subacutely over days. When you see this presentation, you must immediately recognize it as an unchecked autoimmune cascade. It demands rapid, localized mechanical and pharmacologic suppression.
Right here, we see the classic Dawson fingers on a sagittal flare MRI. Notice how these periventricular, pericallosal, ovoid lesions radiate completely perpendicular to the lateral ventricles. They are the definitive radiographic hallmark of the inflammatory breach along the deep white matter tracts. They confirm, without a doubt, that the CNS barrier has been compromised by autoreactive lymphocytes.
Module 1. The Acute Flare Matrix. Now, the crucial point here is the non-negotiable chronological escalation of therapy. The absolute first-line mandate to arrest that acute inflammatory cascade is strictly high-dose IV corticosteroids, specifically intravenous methylprednisolone. Oral steroids just aren't going to cut it here. But if the patient is entirely refractory and those severe deficits keep progressing despite the IV steroids, your absolute mandated next step is plasmapheresis. You have to aggressively step up to mechanically filter out those offending autoantibodies and inflammatory cytokines from the plasma.
Let's establish our first clinical variance box. Say a patient presents with new-onset painful vision loss from acute optic neuritis. That strictly demands immediate IV corticosteroids. On the flip side, preventing that same patient from experiencing future visual loss mandates entirely different maintenance therapies. You absolutely cannot cross these streams. You don't use maintenance drugs to fix an active flare, and you certainly don't use acute steroids to prevent lesions a year from now.
Moving on to Module 2, Chronic Disease Modification.
What's absolutely fascinating here is the sheer modern superiority of targeted monoclonals. Take ocrelizumab. It's an anti-CD20 monoclonal antibody. It strictly and aggressively depletes circulating B cells, completely halting their antigen presentation to T cells within the CNS. This high-efficacy biologic is mechanically miles ahead of the classical modulators, like interferon beta and glatiramer acetate. Sure, those classical agents were historically first-line, but today, they yield demonstrably inferior efficacy compared to modern B-cell depletion protocols. In our second clinical variance box, I want you to conceptualize these disease-modifying therapies as your progression shield. Agents like ocrelizumab strictly reduce annualized relapse rates and slow down the overall accumulation of axonal disability. And this is vital, they do absolutely nothing to arrest an active acute flare. The shield prevents the next fire, but it won't do a thing to extinguish the fire currently burning down the house.
Module 3, Symptomatic Targets. The demyelination of the corticospinal tracts creates profound upper motor neuron lesions. We're talking severe, painful spasticity, hyperreflexia, and weakness. To relieve this specific muscular destruction, the strict pharmacologic mandate is essential GABA B agonist, like baclofen, or an alpha-2 adrenergic agonist, like tizanidine. Now, looking at the autonomic dropout, specifically the neurogenic bladder, you have to rapidly identify the bladder state. A hyperreflexic or spastic bladder driven by detrusor overactivity firmly mandates muscarinic antagonists, like oxybutynin, to shut down those erratic contractions. Conversely, if your patient presents with a flaccid bladder leading to overflow incontinence, the mandate completely shifts to cholinergic agonists like bethanechol or intermittent catheterization. This brings us to our third clinical variance box, which emphasizes absolute mechanistic isolation. Treating upper motor neuron spasticity with baclofen or incontinence with oxybutynin is purely palliative. These interventions operate entirely independently of both the acute inflammatory and the chronic progressive pathophysiologic pathways. They aren't going to save the axon, they just manage the symptoms of its destruction. Finally, Module 4, the master case integration. Let's pull this all together. Evaluate this patient profile blueprint closely. We're testing a 28-year-old female with known MS. She presents with 3 days of profound bilateral lower extremity weakness and a definitive T4 sensory level. She was admitted and treated with high-dose IV methylprednisolone for 5 days, but she completely failed that therapy. Her symptoms are strictly continuing to worsen, and she is now completely incontinent of urine. Notice her current daily meds, ogrizumab and baclofen. The strict clinical question is, what is the single next most appropriate medical intervention for her current hospitalization?
Here is your option matrix. It contains exactly 5 distinct choices, perfectly simulating actual exam conditions. This is a highly competitive spread, practically begging you to address the wrong system at the wrong time. Let's break down exactly why most people fall for these traps before we execute the correct mandate.
The diagnostic trap embedded here is honestly brilliant. Her sudden urinary incontinence heavily tempts you into selecting option B, adding oxybutynin. But doing that is just a symptomatic bladder rescue. It completely ignores the catastrophic, ongoing spinal cord lesion that's actually driving the incontinence. And her daily meds? They're listed to tempt you into tweaking her chronic disease-modifying therapy. You might think about increasing ocrelizumab, option A, or switching to glatiramer, option E, but you never ever adjust a progression shield during an unchecked acute flare. As for option C, IVIG, while it's great for Guillain-Barré or myasthenia, it is absolutely not the standard escalation for a steroid-refractory MS flare.
So for the actual assessment execution, you've got to rely on the acute flare matrix. The prompt strictly demands the next most appropriate intervention. You must recognize the total failure of the primary acute therapy. Those 5 days of high-dose IV steroids did nothing to arrest the cascade. Therefore, you forcefully select option D, plasmapheresis. You have to initiate a mechanical plasma exchange to rapidly strip the autoreactive antibodies from her system and halt the exacerbation. As we wrap up this explainer and finalize our mastery of this matrix, I want to leave you with a crucial thought. We can filter the plasma, we can aggressively deplete the B cells, and we can palliate the spasticity. But when both our acute mechanical filters and our complete cellular depletions hit their absolute limits, what future molecular mechanisms will finally completely arrest neurodegeneration? Think deeply on that as you take these uncompromising clinical mandates into your practice.